Good afternoon, everyone, and thank you for joining Neurotech International today. It's my pleasure to present to you a summary of the company's Phase 1/2 clinical trial results for our broad-spectrum cannabinoid drug product, NTI-164, in children with pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, PANDAS, and pediatric acute onset neuropsychiatric syndrome, PANS, collectively PANDAS-PANS. I trust all of you on today's call have had a chance to read the announcement that was launched with ASX this morning, and shortly thereafter, the investor presentation, which summarises the key findings of this world-first trial. Before I commence today's presentation, I would like to express my sincere thanks to Professor Russell Dale and Professor Michael Fay, the co-principal investigators of this trial, and to their patients and families who were willing to participate in this world-first trial. This initiative was conceptual in late 2022 as we researched the potential benefits of NTI-164, given the correlation between PANDAS-PANS and neuroinflammation in about 80% of cases. Investors will note that NTI-164 exhibits potent neuroinflammatory benefits in cell culture models. To have completed a Phase 1/2 trial within 12 months is exceptional translation from hypothesis to real-world outcomes in patients. We are exceptionally proud of the results we're presenting today, as NTI-164 has shown remarkable positive clinical improvements in these patients after 12 weeks of treatment versus their baseline or day zero clinical status. I would also like to acknowledge and thank our contract research organisation for their seamless execution in managing this trial for Neurotech. I remind investors PANDAS-PANS is a clinical diagnosis given to children who have a dramatic, typically within 1 day, onset of neuropsychiatric symptoms, including obsessive compulsive disorder, OCD, and or restrictive eating. Children may exhibit repetitive tic movements, become depressed, anxious, moody, irritable, aggressive, and have difficulty with schoolwork. The cause of PANS is unknown in the majority of cases. However, the disorder is hypothesized to be triggered by infections, metabolic disturbances, and other inflammatory reactions. PANDAS is considered a subset of PANS. Slide 2 is our standard disclaimer for today's call. I remind all participants the company will be making forward-looking statements which may be predictive in nature and incorporate an element of uncertainty and risk. Slide 3 gives an overview of PANDAS-PANS. As I mentioned, PANS and PANDAS appear suddenly in young children, accompanied by these other confusing and distressing symptoms. This disease has now World Health Organization recognition with the International Classification of Diseases, or ICD-11, for the first time in 2022. The diagnosis is by exclusion, which is to say other medical issues are ruled out. Importantly, untreated or unrecognized manifestations of PANDAS-PANS can increase the risk of obsessive compulsive manifestations and tics during adulthood. So, therapeutic interventions are crucial. Current interventions treat the symptoms, treat the source of the inflammation, and treat disturbances of the immune system. Slide 4 highlights how PANDAS-PANS is diagnosed and treated. Neurotech is excited by the establishment of diagnostic criteria in 2015 and subsequently treatment guidelines in 2018, as it provides a set of clearly defined rules for clinicians for the disorder. This is important for new drug therapies such as NTI-164 and the potential for future incorporation into these guidelines. If we are ultimately successful, we see NTI-164 as a recommended first-line agent in the treatment of this disease. First-line or initial use is reflective of the fact no one else has made it to market, so the first treatment approved is typically given first. Our patients in the trial were moderate to severe PANDAS-PANS patients. Off-label use of antibiotics, steroids, intravenous immunoglobulin or IVIG, and intensive behavioural therapies are used. It is important to consider how sick these children are, with moderate cases considered distressing and interfere with daily living across 50 to 70% of waking hours, while severe forms are incapacitating, life-threatening, occupying 71 to 100% of waking hours. Treatment is complex. There are no US FDA or Therapeutic Goods Administration, TGA, or European Medicines Agency, EMA, approval for any drug therapy in PANDAS-PANS. The opportunity is enormous. Slide 5. In light of what I've just said, this is a very serious condition in these children. We note comments by Aspire Care whose mission is to improve the lives of children and adults affected by PANDAS, and related encephalopathies. Quote, "We encourage clinicians, teachers and providers, extended family and friends to understand the human aspects of PANDAS symptoms, as symptoms are often so distressing, causing high levels of caregiver burden. This drives the market need and our clinical development plans for NTI-164. Turning now to slide 6, the trial design. NTI-PANDAS-1 is a single-arm, open-label phase 1/2 study, phase 1/2 clinical trial in 15 paediatric patients with a clinical diagnosis of moderate to severe PANDAS to determine the efficacy and safety of orally administered NTI-164. The primary endpoints of the trial are changed from baseline at 12 weeks for the revised Children's Anxiety and Depression Scale, parent-rated, RCADS-P score, and Clinical Global Impression, CGI, of severity and improvement and therapeutic effect, also known as the efficacy index. Secondary clinical endpoints include other gold standard validated assessment tools, Yale Global Tic Severity Scale, or YGTSS, Children's Yale Brown Obsessive Compulsive Scale, CIBOC, Connor Scale for ADHD, and a quality of life measure, EQ5DY. Safety was monitored and measured by full blood examinations, liver and kidney function tests. Adverse events were assessed and evaluated by delegated study staff throughout discussions with the participant at week 4 and by phone calls made to them throughout the study and by clinically significant laboratory results. Data on the unique blood transcriptomic and or epigenetic signature associated with PANDAS, which Professor Dale talked about a couple of weeks ago, are not available today and will be part of the subsequent data analysis and disclosure in a future period. This data will be a world first and could identify novel biomarkers of the disease and provide mechanism of action data for NTI-164. Slide 7 highlights why we chose NTI-164 for this indication. We've already provided investors strong safety and efficacy effects of NTI-164 in autism spectrum disorder back in March 2023, over 52 weeks. Preclinical and clinical studies to date have shown NTI is a powerful neuroanti-inflammatory modulator, can suppress a wide range of inflammatory cytokines and improves neuronal cell viability. As I mentioned, neuroinflammation is hypothesized to be relevant to 80% of cases. Professor Dale, our co-PI, has around 30 PANDAS children under care, and he has a strong interest in these clinical trials. His participation in part was also a function of the fact that NTI-164 exhibited long-term benefits in autism. Slide 8 summarizes the baseline characteristics of our 15 patients. The mean age of enrollment was 11.9 years, 60% were male, 100% of patients had PANS, with 0 diagnosed with PANDAS, i.e. the disease which is associated with a streptococcus infection as well. This is perhaps not surprising given PANDAS is a rarer subgroup of PANS in the general population. There are some nuanced clinical nomenclature, which I'm going to be using in future slides, but for now, the Clinical Global Impression, CGI, score for severity of illness at baseline was 20% moderate, 60% marked, and 20% severe. Finally, the RCADS-P, which I've mentioned, the RCADS-P score at baseline was a mean of 83.7, which correlates to a high severity of anxiety and depression. These scores are important as we are seeking to improve these clinical measures over 12 weeks with NTI-164, a key objective of the trial. Turning now to the safety of NTI-164 at 12 weeks. There were no serious adverse events recorded across all doses tested from 5 milligrams per kilogram to the maximum tolerated dose of 20 milligrams per kilogram of NTI-164. Across the 12 weeks of the trial, a total of 9 adverse events were recorded from 3 participants. Of these 9, 6 were possibly related to the study medication and included vomiting, 4 events, 50%, and nausea, 2 events, 22%. The remaining 3 reactions were viral infections unrelated to the study drug, 3 events, 33%. Bear in mind, this is an exceptionally low AE or adverse event rate, given patients typically split the dose to twice a day, giving over 2,500 doses across all patients over the 12 weeks of the study. None of these adverse events were serious and were not considered to interfere with the patient's functioning, and with the exception of the viral infection, did not require treatment. Normal blood chemistry, normal kidney and liver function and vital signs were recorded across the 12 weeks. In conclusion, NTI-164 exhibits an excellent safety profile and minimal patient-specific side effects, consistent with the long-term data we've seen in pediatric autism patients over 52 weeks of daily treatment. Turning now to slide 10, the first primary endpoint of the phase 1/2 trial, the revised child anxiety and depression scale, parent version, RCADS-P. This is a 47 ICE and parent report questionnaire of youth anxiety and depression, representing a scale of anxiety, social phobia, panic disorder, OCD, and low mood. The score below 65 represents low severity. Scores between 65 and 70 represent medium severity and are at the borderline clinical threshold, and scores above 70 represent high severity and are above the clinical threshold. The mean total score for 15 patients after 12 weeks of NTI-164 treatment was 58.2, which is a significant improvement, 30% from baseline, whereas 83.7, equating to a mean difference of 25.5 and a p-value of 0.016. This clinically meaningful and statistically significant improvement of 30% that results in these patients has resulted in these patients, I should say, being reclassified as low severity versus high severity at baseline. To put this into perspective, only 2% of youth in the general population have T-scores of 70 or higher. Upon commencement with NTI-164, all subdomains of RCADS-P also improved measurably at 12 weeks. Social phobia, 32%, panic disorder, 28%, major depression, 15%, separation anxiety, 36%, general anxiety, 42%, and obsessive compulsive behaviours, 47%. With the exception of panic disorder and major depression, all these subdomains were also statistically significant, i.e. less than a 5% probability of chance alone and a p-value of less than 0.05. Turning now to slide 11, as investors may recall from our phase 1/2 autism trial, CGI, severity of illness, is a gold standard physician observer rated scale, synthesizing the clinician's impression of the global state of an individual, ranging from 1 being normal to 7 extremely ill. CGI-S is frequently employed in clinical trials for neuropsychiatric disorders. NTI-164 treatment is associated with a significant reduction in disease severity. At 12 weeks of treatment, the mean severity of illness rating of these patients was 4.1, representing an improvement of 18% from baseline, CGI-S 5. P-value 0.0005, which is highly significant. At baseline, 20% of patients were classified as severely ill, 60% were markedly ill, and 20% were moderately ill. By week 12, patients were classified as mildly ill, 20%, moderately ill, 73%, and one patient, 7%, was classified as markedly ill. This is the patient which acquired a significant infection during the trial, which may have been a factor in their response. Slide 12, CGI improvement, or CGI-I, was strong, showing that after 4 weeks of treatment with NTI-164, 33% of patients were much improved, 67% were minimally improved. After 12 weeks of daily treatment, 53% of patients were much improved, 40% minimally improved, and again, one patient, 7%, had no change, again, which represents that same patient described on the last slide. Investors should note CGI-I does not provide for statistical p-values from the change, i.e. no improvement is assumed at baseline. Slide 13 looks at CGI therapeutic effect. Essentially, this measure operates on a scale of 1 to 16, 1 to 4 being a marked improvement, 5 to 8 moderate, 9 to 12 minimal, and 13 to 16 being unchanged or worse as a result of the intervention being administered. CGI therapeutic effect after 4 weeks of daily NTI-164 treatment resulted in 67% of patients demonstrating a moderate improvement, 33% minimal. After 12 weeks, 53% were moderately improved and 40% minimally improved, and 7%, that same patient, showed no change. As with the previous measure, CGI therapeutic effect does not provide for statistical p-values. Reductions in these clinically used gold standard measures of function and reductions in clinically used gold standard measures of function and neuropsychiatric symptoms were the secondary outcome measures or endpoints, which I'll describe below. Investors should be aware the trial was not statistically powered for any of these secondary endpoints. Slide 14. PANDAS children may exhibit motor and vocal tics, handwriting changes, and or clumsiness with their disease. The Yale Global Tic Severity Scale, YGTSS, is a clinician-rated instrument considered as a gold standard for assessing tics in patients with Tourette syndrome and other tic disorders. YGTSS enables evaluations of number, frequency, intensity, complexity, and interference of motor and phonic or verbal tics. The tool gives ratings in 5 domains: total motor tic score, total verbal tic score, total tic score, motor plus verbal, overall impairment, and a global severity measure. The global severity score has a range of 0 to 100. A higher score on all scales suggests more severe tics or greater impact the tic has on a person's life. Although tics are not part of a core definition of PANDAS, approximately 70% of people with this disorder or disease have tics, being motor or verbal. The mean total severity score for the 15 patients after 12 weeks of treatment was 44.7, which is a material improvement of 14% from baseline, where it was 52, for a mean difference of minus 7.3 and a p-value of 0.07. Interestingly, patient tics overall were classified as mild under YGTSS. However, motor tic severity, a subdomain we measured, improved by 32%, representing a mean change of 3.1 from a baseline score of 15.8. And this, interestingly, as I mentioned, is interesting in the sense that it was borderline statistically significant with p equal to 0.05. Turning to slide 15, the Connor scale measures attention deficit hyperactivity disorder, ADHD symptoms, such as attention deficit and hyperactivity or impulsivity symptoms. The Connor scale is an assessment tool used to obtain observations about a youth's behaviour. The instrument is designed to assess ADHD and its most common comorbid problems in children and adolescents aged 6 to 18. A total score of 15 and above may be suggestive of ADHD. The total score for 15 patients after 12 weeks of NTI 164 was 17.3, which is a significant improvement, 16%, from baseline, where it was 20.6 for a mean difference of 3.3 and a p-value equal to 0.08. Hence, there was an overall reduction in ADHD symptoms trending to a score of 15 or less potentially, which is suggestive of no ADHD symptoms. Slide 16, we looked at efficacy related to the EQ5DY assessment or youth assessment. This includes the simplicity of a descriptive system and measures health across 5 dimensions and a general rating of health on a visual analog scale of 0, worst health, to 100, best health. Basically, this is a very standard measure of a patient's quality of life. The dimensions include mobility, self-care, washing and dressing, usual activities, i.e. school, hobby, sports, playing and doing things with family or friends, having pain or discomfort and feeling worried, sad or unhappy. Patients' quality of life as measured by EQ5DY assessment improved considerably between baseline and 12 weeks of treatment. The mean total T-score after 12 weeks of treatment was 83.5, which is an 18% improvement from baseline, where it was 70.6, representing a mean difference of 12.9, with a p-value which was borderline statistically significant, albeit not powered for this outcome as the other secondary outcomes, and that p-value was equal to 0.05. If you recall earlier in my presentation, I mentioned a quote from Aspire, who recognises the symptoms of PANDAS are often so distressing, causing high levels of caregiver burden. Here we provide some evidence that the patient themselves feel that the overall quality of their life has improved substantially while on treatment with NTI 164. A 2015 scientific paper actually looked at the quality of life in these patients and found significant impairment in youth with PANS, and youth with comorbid tics had lower self-esteem, poorer family functioning, and were more limited in their daily activities because of emotional and behavioural problems versus youth without the disorder. Finally, turning to slide 17, our secondary efficacy measure, SIBOX. The core symptoms of PANDS are OCD-like behaviours or restricted eating. Abrupt, dramatic onset of OCD is a diagnostic criterion for PANDS. According to the PANDAS Physicians Network in the US, traditional OCD presents with mild obsessions and compulsions that become more involved and burdensome over time. In traditional OCD, symptoms tend to be persistent with minor variants in symptoms, often referred to as the waxing and waning effect, whereas in contrast, PANDS OCD presents with a sudden onset, typically from mild or no symptoms, to somewhat debilitating in an abrupt amount of time. The SIBOX scale, Children's Yale Brown Obsessive Compulsive Scale, is designed to rate the severity of these obsessive and compulsive symptoms in children aged 6 to 17 years. PANDAS pediatric patients exhibit severe forms of OCD that appear suddenly, as I mentioned, and they are accompanied by other confusing symptoms. The mean score for 15 patients after 12 weeks of NTI-164 treatment was 30, which was an improvement of 10% from baseline, whereas 33, a mean difference of -3, p equals 0.96. The children were technically downstage from extreme symptoms to severe symptoms based on the change in the scale. Turning to slide 18, our conclusion. We are absolutely delighted by the results of this world-first application of NTI-164 in PANDAS patients. It strengthens our resolve that the benefits of NTI-164 are associated with neurological disorders where there is persistent or progressive neuroinflammation. This underscores our strategy to focus on pediatric diseases where this manifests and no safe and effective treatments are available or are limited. The results presented today in the context of the challenges in treating PANDAS is very encouraging. We have identified an intervention in NTI-164, which has exhibited excellent safety and tolerability, but was also able to significantly improve these children's function across a wide range of well-established clinical manifestations relating to severity of illness, OCD, anxiety, depression, tics, ADHD, and quality of life. As you can see, Professor Russell Dale, the co-PI on the trial, was equally pleased with our findings by way of his quote. We certainly look forward to our genomic analysis of these patients, which we anticipate will provide a wealth of information on how NTI-164 is benefiting these patients through the identification of the mechanism of action and novel biomarkers of disease. Finally, our summary. NTI-PANDS-1, our phase 1/2 trial, is the first ever broad-spectrum cannabinoid therapy to show a benefit. All psychometric endpoints studied showed clinical improvement over time, with statistically significant and clinically meaningful improvements shown for the two key primary endpoints as discussed. As investors will know from our past disclosures, patients have voluntarily elected to move to the extension phase of the trial to 52 weeks of treatment, and several are now being treated as adults, i.e. over the age of 18 years of age. As patient compliance has been excellent to date, we don't yet have any real-world data on the rapidity of symptoms returning if patients cease use with NTI-164. However, based on our experience in autism, where symptoms returned after only a few days without NTI-164, we anticipate in PANDAS these children will require chronic administration, which increases the value of the intervention quite markedly versus a once-and-done therapeutic approach. There is clearly a market need for new and effective therapies in PANDAS, and Neurotech are now considering what follow-on clinical trial options may be available in Australia and the US based on this excellent data. Finally, our orphan drug designation applications in Europe and the US are well advanced, and if successful, they would confer 10 and 7 years market exclusivity respectively for NTI-164 and PANDAS. And that's slide 20. That's essentially the conclusion for today's call. I'd like to turn the call back over to the operator for any questions. Thanks, Lexi.
Thank you. If you wish to ask a question, please press *1 on your telephone and wait for your name to be announced. If you wish to cancel your request, please press *2. If you're on speakerphone, please pick up the handset to ask your questions. We will now pause for a moment for questions to register. There are no questions at this time. I'd now like to hand the conference back over to Mr. Duthie for closing remarks.
Thanks very much, and thanks everyone for joining the webcast and the conference call today. We certainly are delighted by the results delivered, albeit somewhat frustrated with the response in the financial markets today. But those who support our company and those who believe in the intervention we have and the effect it has in these paediatric patients, be rest assured, as a company, we are doing everything we can to materially increase shareholder value over time. And PANDAS PAN is yet another example in 2 indications now where this intervention has shown a benefit in these paediatric patients. So thank you everyone for joining, and look forward to speaking to you soon.